I admit the public now.
Yes, please do, Tracy. Just let me know when we've got everybody on the call.
Yeah, I've got nobody waiting and I'll keep an eye on it.
That's great. Okay, good afternoon, everybody, and welcome to the November meeting of the Integrated Care Board. Stoke-on-Trent Integrated Care Board meetings are in public, but they're not public meetings. I would just ask if all cameras could be off except for the chair and those presenting items on the agenda, and if everybody could make sure that their microphones are on mute, that would just help with the sound quality. I'll invite questions that have been submitted in advance from members of the public at the beginning of the meeting, and we will have an opportunity at the end to also take questions on any items that have been covered during the course of our meeting. And finally, before we get into apologies, I just want to let everybody know that for transcription purposes, we are actually recording the meeting. So hopefully everybody gives their consent with that. So we have apologies registered, Jill, from Heather Johnston and Lynn Tully, I think, is attending. Patrick Flaherty and Richard Harling is attending from Staffordshire County Council, and Neil Carr and Chris Sands from MPUFT is attending, and Josie Spencer, Non-Executive Director for the ICB. Any further apologies that we've received, Jill?
That's all I have, Chair. Okay,
thank you. You'll see from the enclosures that the Leadership Compact is enclosed at enclosure 1. The compact is a very important document that's used in all of the meetings transacted by the ICB, and it guides the way we conduct our business, and we'll return to that at the end of the meeting to review that process. So in terms of quoracy, I understand, Paul, we are now quorate.
That's correct, David. Yeah.
Yeah, thank you. And can I just ask, are there any conflicts of interest in relation of any items on the agenda today, other than those that are listed on the enclosed register? So if that's not the case, let's turn to the minutes of the meeting held on the 21st of September. And if we could just go through those for accuracy first, and then we'll pick up any actions arising. Page 1, page 2, page 3, page 4, page 5, 6, 7, 8 and 9. Everybody happy to ratify those as a true and accurate record of the discussion last time? Thank you. We have the action log attached for progress, one item. Tracy, I'm taking the virtual wards issue that's identified there will come back in due course.
Yes, Chair.
Okay, and just checking that nobody has picked up any items arising from the minutes that's not covered on the action log. Okay, thank you. So Tracy, if we could move to the questions that we've had submitted in advance of the meeting, I'd just be grateful if you would take us through those. And I know colleagues are signed up to actually give an update where we can.
Thank you, Chair. So the questions have come from Mr. Ian Syme. And the first question, and I'll take the question and then let somebody answer if that's okay with you. I put a question re the worst case scenario deficit of 141 million that was mentioned in October 2023 board paper. The ICB's response mentioned a further risk, namely achieving and receiving elective recovery fund payments in full. At UH&M board, Wednesday 8th November, UH&M Finance Director mentioned that clarification re ERF by NHS England was imminent. Is the ICB now informed as to this recent clarification, and what is the impact of any recent clarification on the worst case scenario ICB deficit?
Thanks, Tracy. So Paul, are you going to give an update on Mr. Syme's question in regards to the ERF?
Yeah, will do, David. Yeah, thank you for your question, Ian. Yeah, so we have had the guidance in that you referred to that has provided clarity in terms of where we are with the ERF for the rest of this year in terms of the impact of the industrial action. It's resulted in a reduction in what's called cost weighted activity, but basically the amount of elective activity that we provide. It's reduced the target down. Ours was 101% down to 100%. So that's based on pre-COVID levels of activity. So we know that part of it. So we're clear now what the target is. We're clear on the money side. The issues I was referring to last time, the risk in the position is 17 million. That actually is not affected by that guidance. We still have the same issue before or now as we had before, which is there is some risk to our position, but it's around interpretation as opposed to the guidance itself. So the interpretation of the guidance around the way that we pay for activity provided for us by, in our sense, out of system providers. So those acute providers who provide care to our patients, predominantly that's about UHDB, University Hospitals, Derby Burton and Royal Wolverhampton Trust. So that risk, Ian, of 17 million that I referred to is still the same number. It's still there as a risk. I still believe that we will be successful, and that's why we've put into our most likely case that that we are in that. But it's going to be in the hands of, potentially in the hands of, regional people to arbitrate. I'm working through with the finance directors of those two organisations. Hope to resolve it myself, but it might be that we have to require some help from regions. So it's basically as you were, the same risk.
Thanks, Paul. Tracy, the second question that you've got. I think you're on mute, Tracy.
Again, Mr. Syme, on the 25th of October 2023, Her Majesty's Coroner Stoke-on-Trent in North Staffordshire issued a Regulation 28 report to prevent future deaths. That report was addressed to NHS England and UHM, but not to the ICB. The report highlighted, amongst other things, His Majesty's Coroner's grave concerns at the lack of a tissue viability team at weekends. Considering the ICB safety remit, how are safety structures within the ICS aligned so that such important interventions by His Majesty's Coroner, namely Regulation 28 reports, are universally acknowledged within the ICS and supplementary actions become swiftly embedded so that issues raised by His Majesty's Coroner are sustainably fully addressed? I'm somewhat puzzled that in this case the report was only addressed to NHS England and UHM and didn't include the ICB.
Thanks, Tracy, and welcome, Becky. You're going to pick that question up for Ms. Symes, yeah?
I am, yes. The report and where they go is very much determined by the coroner. So what we have in is a number of safety netting in the event that we are not informed of anything along these lines. Our providers do actually notify us of anything that comes through from the coroners, and we also have CQRM as a way of managing that through and identifying learning across the system. At the same time, we also make sure that we are aware of any of the PFD, so that you know, sort of the potential reports that come through via the coroner's website, both on a national and a local level, are also included in our safety and assurance discussions that we have at Quality Safety Committee and also at our system group with regards to actions that need to be undertaken.
Thank you, Becky. Tracy, and I think there is a third question from Ian, yeah?
Yes, and finally, at Monday's Staffordshire Review Scrutiny Committee, that was the 13th of November, with West Midlands Ambulance Service present, it was mentioned that there seems significant anecdote that self-presentation at emergency departments was increasing. A significant proportion of such self-presentation seemed to be Category 2 and Category 3 patients that would normally be transferred by ambulance. There seems some logic that individuals will self-present even with emergency conditions, given at times ambulance delays in responding. Is the ICB cited on this self-presentation at emergency departments?
Thank you, Tracy. Phil, are you picking up
Yes.
Ian's question in that regard? Thank you.
Yes, thanks, Chair, and thank you, Ian. Very insightful question, in fact. So we're unable to do a full statistical analysis based on the data we see because patients coming into ED via ambulance or walk-in are not categorised in that same way. But what we can definitely see is that in periods, and we've looked back over the last 18 months, in periods where we've been under the most pressure operationally, resulting in longer ambulance delays, both in terms of on the drive at the hospital and response times, that the proportion of ambulance conveyances to hospital reduced slightly and walk-ins increased correspondingly. So there is a logic there, as you mentioned. I mean, the important part for me out of all of this is that we maintain the focus and commitment to make sure that the actions we're taking by all partners in the system, including the ambulance service, are working to reduce the overall delays in relation to ambulance response times and time on the drive at hospital. We know we've been in a more challenging space the last few weeks, but we've still seen an almost 30% reduction in over 30-minute delays at UH&M this year to date compared to last year to date. So we are making progress, but clearly a great deal more work to do here. But thank you for the question.
Thanks very much, Phil. That concludes the questions, Tracy, in advance. Ian, thank you for your attendance and thank you for submitting those questions. If we could move on to item 7, an important item, I'd like to welcome Gemma Finn and Peter Tomlin, who are joining us today to take us through the Changing Futures programme. Peter, welcome. Gemma, welcome. And if I could hand over to you to give us a brief overview, and then we'll pick up any points or questions that the board may have.
Thank you, David. Great stuff. Good afternoon, everybody. If we could put the slides up, I'm Peter Tomlin. I'm the Director of Adult Social Care, Health Integration and Wellbeing at Stoke-on-Trent City Council. I've just handed Gemma.
Hi, I'm Gemma Finn. I'm the Strategic Manager for the Changing Futures programme based in Adult Social Care, and it's great to be here, and thank you very much for inviting us today.
Brilliant. Just go to the next slide. So Changing Futures, we're going to go through this fairly quickly in 10 minutes, but basically for colleagues that may have known Fulfilling Lives previously, effectively it's about how we support people that experience multiple disadvantage, so homelessness, offending behaviour, substance misuse, mental health difficulties, maybe a victim of domestic abuse. So effectively it's how we try to do that. Now, we are one of many, but not many. So we are one of a set of local authorities and areas that have dropped down funding, but that funding is time limited. It runs to the end of March 2025, and we don't know what the funding will look like beyond that. I'm aware that, of course, between now and then, we will have an election in that process. So looking at what that will look like, we don't know. So we're accounting for the current programme of work and recognising that this is particularly in the city of Stoke-on-Trent an issue of how we're going to work together. It's a multi-agency approach, and broadly it's looking at the wider systemic problems and starting to draw how we're going to work together on some of those issues going forward. We have an evaluation process with the university, and indeed we're looking at what could be a sustainable model going forward on the basis of not knowing what the funding is. So that's where we're up to, and I'll hand on for Gemma to take us through the entire programme.
Okay, thank you, Peter. Can I have the next slide, please, if that's okay, Imogen? So just I wanted to start just by putting it in context from a multiple disadvantage perspective, that we estimate that there's at least 3,000 people in our city that experience multiple disadvantage. A lot of those individuals are engaged with predominantly universal services. However, there is a significant number that are engaged with specialist services, and often on a cycle of being entrenched with a multiple disadvantage, which often means that there's a difficulty in terms of engagement, and that leads to people becoming stuck within the system. So the work of Changing Futures is to try and support people who are perhaps resistant to engagement with services and who are feeling very much stuck. We're also looking at how we can work upstream with individuals at different points within the system to try and prevent people becoming entrenched. Have the next slide, Imogen. So just to kind of go back a little bit from a historical context, Changing Futures was born from the Voices project, which was Fulfilling Lives, which you may or may not be aware of, and that was funded for an 8-year period. We were one of a number of areas in the country to secure that funding. Voices was hugely beneficial, particularly in terms of how we can coordinate services within that case coordination function. And I just thought it would be really important just to highlight really the significance in terms of the financial impact of that project. Just over, in terms of a 12-month period for individuals that were supported, just alluding to health particularly, there was an overall cost kind of reduction of £470,000, just shy of 480 actually, alluding to both hospital inpatient episodes and A&E attendances. So there was a reduction over that 12-month period from the work of Voices, which is very much mirrored with Changing Futures. Can I have the next slide, Imogen? So our approach within Stoke-on-Trent, as I alluded to, I'm based on adult social care, and I have a core team that are based within us, and it makes real sense for it to be based on adult social care, particularly around a lot of the customers that we work with have care and support needs, and we're really trying to support those individuals creatively and flexibly. We're very much based upon lived experience being the golden thread throughout the project, working closely with expert citizens to really make sure that we are taking that person's experience of having been through the system, what's worked and what hasn't worked, and using that to drive it forward. We've got the MARG, which I'll come on to a little bit later. So it's how we work with complex cases in a meeting arena. Case coordination model, as I alluded to, so how we can support that individual to navigate the system, bringing those services together. Volunteering and recovery. We've also got the expert citizens delivering a training piece across the sector, so free training that's available for a number of different professionals and volunteers to really make sure people are feeling upskilled to work with this cohort of people. And then welfare benefits and housing expertise is a key part of our project as well, that's commissioned to the Citizens Advice Bureau, more important than ever, particularly with the cost of living crisis, and we see the challenges of that for a lot of people. Can I have the next slide, please? So the impact to date then, so in an 18-month period, we have worked throughout the programme with the different elements that I've described with 335 individuals. The kind of the demographics of that is made up of 60% male, 40% female. I think what's quite stark is the mental health and substance misuse difficulties that are within the kind of complexities of those individuals, and also homelessness. Needless to say, obviously, domestic abuse is often unreported. So whilst that is indicated as being 38%, we suspect that to be higher. And offending behaviours are similarly with that as well. We've had huge successes, particularly around securing people in accommodation, engagement with substance misuse, and also keeping people out of prison following a release. Whilst mental health and substance misuse services are not as high in terms of impact as we'd like, I think this is quite a stark reminder that we're not where we need to be from that perspective. But with the investment into drug and alcohol services, we're hoping that will vastly increase with engagement and the work we want to do in the future with mental health services as well. Can I have the next slide, please? What I really wanted to just share with you as well is the positive case example. So whilst numbers and figures are really good, the actual impact that we've had on somebody's life is what makes all the difference, and why we do what we do. So there's just 3 really kind of concise positive examples of where we really feel that we've made that difference to an individual. We've reduced somebody being kind of subject to safeguarding measures. They've become abstinent from alcohol and they're now volunteering. A lady that was a victim of domestic abuse was supported to give evidence against the perpetrator, who's now in custody. So she's now leading a real kind of positive quality life. And then the final one, a care leaver of the children's services, who's now not isolated in his property, and is engaging in activities outside of his home. So huge difference, you know, just 3 of many of the positive examples. Next slide, please. And again, very busy slide. You might might take some time to look at this afterwards, but just wanted to share with you the outcomes that we're reporting into, and we're currently, as Peter alluded to, evaluating all of this information, which we can certainly come back and share that with you once we have all that available. But again, our aim is to have fewer presentations at A&E, fewer inpatient episodes, looking at the criminal justice element of things, how we can really have that difference across the system, and also getting people involved, you know, using that experience in a positive way to make that difference across the system as well. Next slide. And then I just wanted to draw your attention really to how, you know, it's really important of how we interact with the the wider health system, and how we can really make sure that people that are most vulnerable to poor outcomes within our population are really supported, and the challenges really that faces as well. And often people have those barriers that they face in terms of stigma, mistrust, and they feel excluded. So it's really important that we can support people that have got addiction and mental health issues in the most flexible and appropriate way as well. And the next slide, please, Imogen. The MARG that I described in one of the earlier slides is a really important focus as part of Changing Futures multi-agency resolution group, which sits on a monthly basis. We've had an independent chair that's been appointed to the role of facilitating these meetings, and these are for very complex cases where we literally feel that we are experiencing a lot of system and service barriers with these cases. So we've got really, really good buy-in from statutory and non-statutory services, senior leaders attending from police, probation, adult social care, health, housing, to name but a few. And we're really looking at how we can provide a flexible and innovative approach. And we've had some very good outcomes with regards to that as well. And then what we do is we take those themes and we bring those to a communities of practice arena where practitioners will look at how we can really drive forward some pragmatic solutions to those system challenges. Next slide, please. And just some key themes that are coming through what we're seeing is the barriers to people securing accommodation, homelessness. A key topic we're looking at the minute is arson and fire settings. So people who've got those convictions, how we can support people into safe accommodation that's safe for the community and those individuals. Substance misuse, poor mental health, involvement with the criminal justice system, and often those behaviours that can be unpredictable. And I think we've got the last slide now. So how we've really kind of contributed to the positive outcomes through the MARG is having that effective case coordination. What's really important is how we share that risk across the sector. So we're not carrying that within one particular organisation, how we're sharing that information. And last but not least is having those lived experience experts involved with the MARG to really drive forward how we can make that difference with those that have been in that situation. And thank you. So I've spoken a lot there, but I appreciate your time. It's such an exciting and sadly short-term programme, but we do hope that we can continue post-25. So I don't know if anyone has any questions or if we've got time.
Yeah. So Gemma, Peter, thank you very much. And Gemma, the passion for that certainly came through in that great overview that you've given. First comment I'd just like to make is that you really brought to life, I think, the quadruple aim of improving outcomes, you know, tackling inequalities, enhancing productivity and value for money, and helping us to support that broader social and economic development across the city. So thank you for that. I think it's really strong that comes out. I guess just a couple of quick points before I hand over to Paul, and I think Julie's got a hand up as well. Just in terms of the engagement, just wanted to check, is this linked into the portfolio work that we're undertaking around mental health and any other cross-cutting portfolios? And I guess secondly, we've got a piece of work coming up with the city, where we're talking about the refresh of the strategy for the city and how that will align with the refresh of the joint forward plan and the operational plan for the ICS. So it's obviously it's very good that this is around now, because it is going to really the core of, you know, people who are some of the most vulnerable people, and can also be very, very high impact, and particularly, you know, when you described arson, fire setting, etc. We know that some young people end in massively expensive out-of-area placements when they begin to attract those labels. So we'll pick those up in a moment. We'll just go through some of the questions that we've got. Paul, if I could bring you in first.
Yeah, thank you. Hi, Gemma. Nice to see you again. So, Gemma, you know, I'm a huge supporter of this programme, and, you know, was involved when it first came into Stoke-on-Trent. Fantastic sort of exposition, really, of the value that this has added. Couple of comments, really. To my mind, it's integration around the person, sort of par excellence. This is what we're all about, isn't it? About integrating around the individual. David, you quoted the sort of, you know, the 4 ambitions of the ICS. What I see in this as well is the 5 Ps coming out of the ICP strategy, around personal responsibility, prevention, personalised care, people and communities, and productivity. It's all in there brilliantly. I love the fact that it's based on lived experience and expert citizen and so on. You know, it's got all of the right things in there and so on. One of the reasons why I was supportive of it coming here is exactly that question you raised about the sustainability. To my mind, the work that this is doing to help the most vulnerable in our society, we can't afford to lose this, and we need to think now. 2025 will come very, very quickly. So how do we make this sustainable? And actually, how do we learn from this and maybe do more of this, expand this out? So really, that's my sort of, it's not necessarily a question for Gemma, it's a question for all of us. How do we really, really make this sustainable and hang on to it as we go forward? So thank you both for coming and doing this. It was great.
Yeah,
Thanks,
thank you, Paul. We'll bring Peter in if we can, and then Bucky and Julie.
Yeah, just to reiterate the thanks that Paul's given. I mean, it's a great story, a great narrative, but also a great initiative. And nationally, the thinking around how we take forward the improvement programme is kind of slotted into 3 areas. So organisational, if you like, productivity, system-wide transformation. When I say system, I'm talking broader ICS. And critically, and linking to this, and what I wanted to touch on, locality-based transformation and improvement. And we're embarking on our neighbourhood journey, our neighbourhood transformation journey within the ICB and ICS now. And a lot of that conversation is funneling through our places, our upper-tier local authority place forums. But for me, that neighbourhood piece can't come soon enough, because it does everything that you've all just described, that support being wrapped around the most vulnerable proactively, you know, enabling them to not deteriorate at the rate that many are at the moment, and ensuring that we use data, you know, huge quantities of evidence and data to be able to drive our decision making around resource allocation. So, you know, I'm really excited about the journey that we'll go on together through 2024. But yeah, fundamentally, it can't come quick enough.
Thank you. Thanks, Peter.
Thank you, Peter. Bucky?
I think some of the things I was going to point out, everyone has said, just to say great work, and the sort of thing that I personally as a clinician would endorse. That's working together in a multidisciplinary team, and putting the person at the centre of it. I guess my plea, and it may already be happening, is I heard mental health mentioned a number of times, as well as substance misuse. And in the same tone that it started, it would be great to expand that integration to make sure that such successful initiatives are sustainable, because that's the only way it will move forward, and for us not to fragment any further. Thank you.
Yeah, thanks, Bucky. Julie?
Thanks very much. I won't say again what everybody else has said. A great presentation, really passionately delivered as well, totally supported. And sustainability is the key issue. We you know, I don't want to lose that today. For me, there was just that I was building on a little bit about how it cuts across portfolios, but also what Paul said about the 5 Ps. what I was hearing, and it might be that I'm misunderstanding, is that this is the support given, which is fantastic, is often when people are in crisis already. Perhaps that's too strong a word, but in terms of the wider prevention, given the data that actually local authorities have, I think it's absolutely critical that the support that could stop people actually getting to the point at when you're actually having to deliver this support and help people. So that was my point. Thank you.
Thanks, Julie.
I'm okay to come back on some of these. So thank you very much for all your comments. Really, really helpful and great to feel how you endorse these things. And I think, regardless of the outcome of the evaluation that we're looking at, which will look at some of the sustainability issues, the aspects that are real strengths here that we will want to continue with is that multi-agency approach, not a drop and run, but how do we work together and bring the person with you? How do we work across that expert citizens piece? And how does that shape our workforce? How do we listen to people and about their experiences and the Insight Academy piece? And then in terms of personal budgets, some of the aspects that we have there, how do we fix things before they get worse quickly and respond to people? And I think one of the key aspects around that engagement piece is that whilst it works across the ambitions and the 5 Ps, we do struggle a little bit about sort of the portfolio areas because it is by its nature multifaceted. So working out how we link in is going to be key going forward. And in terms of that sustainability piece, I know Chris and I have discussed around our place approach. If we really sat down with the police and housing and fire and indeed, most importantly, our local communities and that neighbourhood approach that you talked about, Peter, I think they would identify some of the challenges and ambitions that they have, and it would fit very well with this model going forward. But we need to buy into that. It's not just about health and social care. This is the whole place and how we would approach that. Hope that makes sense with some of the responses.
Yeah, great. Thank you, Peter. And once again, thank you, Gemma. We will pick this up again. And I'm sure it will come out in the discussion that we're going to have at the end of this month with Councillor Ashworth and the Cabinet in Stoke around some of the priorities going forward for the city. So look forward to that. So thank you very much for coming and making your case so strongly. We've been asked to familiarise ourselves with the programme and the current context of multiple disadvantages within Stoke and the interdependencies with other initiatives and investment within the health system. So thank you once again for attending.
Thank you very much. Thanks for your time and comments.
You're very welcome. So if we could move into item 8, I'm going to hand straight over to Peter on this, given the agenda we have this afternoon and the time constraints we've got, the Chair and Chief Executive report. So Peter, anything that you want to pick out by exception that we haven't got covered on the agenda, over to you.
Yeah, thank you, David. So just very briefly, given time, you'll see that the paper does describe in quite a lot of detail the work that we're doing in year around the recovery programme and assessment of operational targets and delivery aligned with that. So I won't dwell on that because there are papers on the agenda in relation to that. What I would say is, however, we're focusing equally, although it is very difficult at the moment to do it, but we're making sure that we do focus equally on 2024, 25 and planning for the future. So whether that be the work that we've just talked about in terms of neighbourhoods and the evolution of that programme, or just the very granular building up of our 24, 25 plans, we are making sure that we approach the world with that, to use a previous chair's terminology, split lens approach to the world. So rest assured that in addition to all the detailed work that we're doing in terms of recovery, we're making sure that we do equally focus on what is on the horizon. I'll leave it there because I'm conscious of time, Chair. Happy to take any questions.
Thank you, Peter. Just pause there in case there are any questions on this report. Chris?
Thanks, David. Yeah, it was just in the paper it talked about planning and talked about following the same approach as 23-24. I think there's quite a bit of learning that we need to take from the recovery plan work that we're doing at the moment that should then inform planning going forward. And particularly for me, I think we need to do some focus work around how do we get our demand assumptions, our capacity, our performance standards and quality standards, our workforce and our finance in equilibrium, and that will provoke some difficult conversations, but we need to have them as part of the planning phase rather than when it's too late.
Good question, Chris. Peter?
Yeah, I fully agree, Chris, and you know, I welcome comments from Mr. Sands, because he's hugely experienced in terms of the planning piece in a number of different systems. So I do agree that triangulation of quality, finance, activity, workforce is absolutely critical. What I would also argue for, and I will be suggesting that we do this as part of planning for 24-25, is look at a slightly longer period, so perhaps 3 years, because I think there is something for me about that immediate planning piece is of course important, because we need to convert plans to transact plans within our operational plans for our clinical colleagues, our managerial colleagues, etc. But to ensure that we're sustainable, surely we've got to look at a longer period, acknowledging, of course, the variability within that, the risk of variability due to another election, comprehensive spending reviews, etc., etc. But I think we need to make sure that that triangulation piece, relationship fundamentally between the clinical operating model and our resources that are available, is done over that 3-year period. But absolutely support Chris's comments. Yeah.
Thanks, Peter. Thanks for the question, Chris. Okay, so if everybody's happy, let's move into, we note the updates in the Chair and Chief Exec report, and move into item 9, the System Recovery Plan. Paul, you're joining us to introduce this.
Yeah, thank you, David. The report sets out where we've got to. I think we've got a huge amount of detail now behind the recovery plan, so really pleased with that. We've defined what we call products. We've got 25 of those. Those are discrete outputs that we can measure and improve that we've done. And we've got the team working on those. In terms of the governance behind that, Alex Robertson from the TDU meets with the team of people who are responsible for the delivery of those products on a weekly basis, and I join them monthly, and then we report that in through the System Performance Group and up into the System Finance and Performance Committee and into Chief Execs and the Provider Collaborative too. So we've got all of that covered off, and I think we've now got that detail that we agreed that we needed in order to have a real strong grip on the recovery. As ever, some things are working really well and some things still work in progress. So the one thing that I think is working really well so far is the grip and control around the continuing healthcare program itself, and putting the patient first is absolutely what we're about, ensuring that the right patients get the right care when they need it. And we know from the work that we did previously that the CHC financial problem is actually also a clinical problem. We know that we're overprescribing care for patients, which is actually not leading to the best outcomes for those people. So that's where this is a really good initiative. It's not about just saving money, it's about making things better for patients. And we've now got a huge amount of evidence of impact that we're having in terms of patient care, which is also having a fantastic financial impact too. So in terms of the financial numbers, the part year effect, the effects of continuing healthcare savings, we've now generated into 23-24, where it's 10.6 million already, and that equates to a full year figure of 31.9 million. And you might remember we set a run rate target of 100 million by March. So far we are on track for that. It's still a long way to go. Clearly 32 million is good, but another 68 to go. But we still believe that we can do that. And I think the fact that this is a whole system piece is where the power is really in this recovery programme. The involvement of the Provider Collaborative that Tracy Bullock leads, the CHC Provider Collaborative that Neil Carr leads, that's really where we've got all system partners coming together to make this happen. And we know that we can't get the right care for our patients unless we look at the whole process through from admission through discharge, and through to those patients who need to go on to CHC. So I think that system buy-in, and commitment, and a huge amount of work which is happening on the ground is what is leading to these improvements. So really happy with that progress on CHC, and thanks to system partners for what they've done so far. In terms of you will recall we agreed 7 key priority areas, and then there was an 8th, which was medicines management across the system. Of those, I think probably draw out care homes, which is an absolutely fundamental piece, which is being led by Richard Harling. He's on the call. He might want to come in at some point. And very grateful to Richard for kind of doing this outside of his day job, if you like. And through care homes, we know that a large number of patients who are frail, who are potentially end of life, those patients are often in care homes, and those patients are also receiving continuing health care. So that's really why we see the care home piece is absolutely fundamental to changing the number of patients who currently are referred from the care home, where they're safe and happy, into the acute hospital, where obviously some patients need to make that journey. Others we think would be better off placed staying in the care home. And Richard's leading the work around respect documents, as we call them, which is ensuring that each patient has a care plan, a personalised care plan. And on the risks, Chair, we've flagged some of the risks around capacity, and this is probably where this is coming into fruition. There's a huge number of respect documents to be worked through. We haven't yet got the capacity in place, and we are working through that. Richard and myself have met with Rachel Gallio from primary care team this week, so there's more to do basically in this regard. We've made a good start, but we need to do a lot more if we're going to really get the full benefit in terms of the continuing healthcare opportunity, but also really importantly that those patients who don't need to go to A&E don't go to A&E. So there's more to do on that one, and we thought it was important to flag that risk to the board, that we are behind where we wanted to be on that particular work piece, but hopefully giving some reassurance that we're onto it. So I think that's probably where we are in terms of the board decision. We're asking you to note that we now have 25 products. We've set those out. Hopefully you can see the detail there. To note the emerging risks, and I've touched upon those around capacity. And finally, in terms of the reporting of those, we're reporting against those 25 products through the mechanism I just described, through the weekly meetings, through the monthly meetings, and that will be captured in a dashboard, which will be available for the board to see whenever it wishes. So, David, that's my update this month on the recovery programme.
Thank you very much, Paul. And I think it's worth just noting the System Financial and Recovery Summit we had last night, which brought together the chief executives, chairs, chief finance officers and non-executive chairs of finance and performance, together with the upper tier local authority leaders and chief execs to go through this. Some excellent presentations there from Steve Grange on continuing care and Richard Harling on nursing homes. A lot of work going on, and as you said earlier, it's really great that we are developing a common purpose around this, and it is one system, one plan that we're operating to. So I have a couple of questions to take. I think I saw Chris Sand's hand up first. So Chris.
I think that must be an old hand, David. Apologies for that.
No problem, Chris. Julie?
Thanks very much. Thanks, Paul. I think just picking up one thing that you really said is really important for me on this. We've got to be really clear. This is not just about the money. It's about doing the right thing for patients, and really make that absolutely clear. And I say that in the context of, given the number and scale of risks that are set out quite clearly in this report, but also the unknown impact of winter. We don't know how that's going to impact as well. So, but we've got to be realistic, I think, but remain committed that this is the right thing. I've just got 2 questions, really. One of the risks that concerns me quite a lot is around the communication with patients and their families, is how are we mitigating that risk so that it doesn't cause undue concern? And the other one in that realism is how this is going to feed into 24-25 planning.
Yeah.
Thanks, Julie. Paul?
Perhaps if I could take the second of those, and perhaps if Paul, EJ could take take the first, if that's okay. In terms of the second, Julie, yeah, absolutely. So there's kind of two parts to it really. The first is the actual savings that we make on CHC itself will of course make a material difference to the financial plan, and that's we set out the goal for 100 million. The 100 million would bring us actually back in line with other systems. It wouldn't mean that we're spending less than other systems on continuing healthcare, and we think that's probably the right sort of sweet spot in terms of, as you say, getting the right care for patients, because patients need care, but not too much care. Too much care is bad for patients, and it's that sweet spot we're aiming for. And that's that 100 million is going to be effectively cash straight into the system. So that's point one. I think point two is around the rest of the programme, which predominantly around ensuring that only the right patients go into acute hospital in the first place. Patients who fall, patients who are frail, patients who are end of life. Those patients do not go into the hospital in the first place unless they need to. We've got a lot of data undertaken, a lot of work undertaken by Lorna Clarkson in our team, which has shown, that we are an outlier in terms of the number of those patients who are going into A&E in the first place and then being admitted. Which again, for the patients who need to be admitted, it's the right place to go. For the patients who don't, it's not the right place to go, and that's where the rest of the programme really comes into its being. Will drive will lead to lower levels of activity into the acute sector, which will, working with my colleagues, in this case particularly Mark Oldham at UH&M, working with him, and if we can achieve that, again, that sweet spot of only the right patients going into UH&M and the other acute hospitals, then that gives us the opportunity in the financial planning to right size the hospital and not build new beds, not open new beds, not try and recruit staff that we can't recruit, not have agency staff coming in, actually hold the capacity of that hospital at the level that it is, and then rebalance within the hospital so that we've got essentially more patients going through elective surgery where we need to catch up on backlogs, and fewer patients going in for urgent care who didn't need it. And essentially that, Julie, is how we then create a financial plan for next year that is right sizing our activity and our money.
Okay, thanks, Julie. Thanks, Paul. And finally, Megan.
Thank you. Thanks, David. I suppose this is a recovery plan, a finance and performance recovery plan. For me, the bit which excites me is that it's a transformation plan of how we actually look after our frail elderly, and how we look after them much better than we do at the moment. And I don't know whether we've got time for Richard to talk about some of the work he's leading on that, but for me, that's the transformation piece. That's how we actually deliver improvements in people's quality of life going forward, and that's the bit which is exciting. So I don't know if we've got any time for Rich to come in or not, but if not, perhaps another time, David.
Yeah, I think given the pressure on the agenda, Richard, I don't know whether you just want to make a quick response to that. I think it would be helpful to have Richard back actually to do this in greater detail, as came through last night at the system financial planning. But Richard, any immediate comments that you want to make?
Thanks, Chair. So first of all, I very much agree with Megan's premise. The common theme throughout the whole recovery plan is how we manage the frail elderly. The approach right across the country at the moment tends to focus on individual organ systems rather than the whole person, and the priority is extension of life rather than quality of life. The unintended consequence of that is significant overtreatment of people, often at great detriment to individuals and at significant cost to taxpayers. Just a couple of stats. So 1/4 of all people in hospital right now have fewer than 365 days to live. And in the remainder of those days, they can expect repeated admissions. So they spend a lot of time on the ward rather than with their family and friends. Every day, 30 people are taken from a care home to hospital, half are admitted and half are taken back again. That's 2 or 3 during the course of this meeting alone. Most of those are avoidable as well. So the real opportunity here is not just a financial one, it's to develop a much more compassionate model of care, one that asks what would we want for ourselves and our family, and challenges whether diagnostic and medical interventions are genuinely doing more good than harm. The rate limiting step here is it's going to take a big change in clinical culture and practice, and I think that's one for us to reflect on. Have we really got enough in here in terms of influencing the hearts and minds of all of those doctors and nurses who are practicing with best intentions, so they genuinely believe they're doing the right thing, but it's not working for citizens, and it's not working for the NHS financial position. So really big opportunity for us. It should be our top priority. Very happy to give you more details about the care home work stream at a future date.
You're on mute, David.
Sorry, Richard, thanks, Paul. I think that would be very helpful for a future meeting, Richard, to have you back just to do some further in-depth discussion around that. Jack, we are fighting the clock, so I'll bring you in for the final question if I can, and then we will have to move on.
Thank you, Chair. Just a very brief comment. So very much agree with the sentiments and the comments that have been raised. One thing I would say is a lot of this work, I guess the natural place for it to sit in the community, and within that community, I think within general practice and primary care. I think the difficulty is it truly is a transformation piece, because I think it's very difficult to ask one particular cohort, for example, in the community, to do that transformation piece when other aspects of the system are having either different expectations or are delivering a different message. So I think that transformation needs to occur in the media, that transformation needs to occur in care home settings, and needs to also occur within specialist care settings. So I think it's very difficult to ask one particular group to act in a different way when everything else around them is giving a very, very different message. Thank you.
Thanks, Jack. Great point. And I think just to take from that discussion, Paul, which has been incredibly helpful about actually, putting this, Megan described it as excitement, in terms of what it can deliver for people. And certainly, Jack's point, Richard's point, Julie's point, etc., has brought that out really strongly, that, this isn't about the money, it's about doing the right thing. And if we can just put an action in to bring Richard back to do a deep dive at the start of a board meeting in the future before the end of the financial year on care homes, I think that would be incredibly helpful. So, Paul, you've taken us to the recommendations. Just check the board are happy to receive those. Thank you. And we'll move into item 10 if we can, the digital update. So, Chris, if you could take us through enclosure 8, I'd be grateful.
Chair, thank you very much, and I will keep my comments brief and by exception, I think, given the time constraints. So first of all, may I introduce myself to those that may not know me. So Chris Eibel, I'm the Chief Digital and Information Officer for the ICB. As I say, I'll keep my comments fairly brief, and I would welcome an opportunity to go into this in more detail at a future date. But I want to provide assurance that we have, across Staffordshire and Stoke-on-Trent, we have a relatively low level of digital maturity. This was determined through a McKinsey study at the beginning of this year that was commissioned by NHS England. It was done up and down England, and against our peers, we have relatively low digital maturity. So that's our starting point. But I'm pleased to say that we have a co-produced digital roadmap, which has been produced not only with our health colleagues, but also with our social care colleagues, that reflects the need that we have across our region. I'll pick out a few areas which are important to note. The electronic patient record at our acute UH&M is due for replacement by September 2027. Now, that might feel like a long way out, but it doesn't give very much time to procure and deploy such a comprehensive system, and that risk is sitting on our ICB as well as the UH&M risk register, but working very closely with Deloitte, who are performing a business case exercise right now, and we're taking the opportunity to bring in our system partners. Of course, that includes our councils as well as primary care, ambulance services and others, to see whether we can identify an integrated solution which will streamline workflow up and down our particular area. The second area I want to pick up on is cybersecurity. The threats are increasing and our defences are similarly increasing. We've put additional investment into this area, and we're right in the throes of implementing a system-wide, and here I'm not just again talking about health, I'm talking about our councils as well, implementing a 24/7 security operations centre with improved tooling. And I would highlight that actually it's not the technology that's our biggest threat really, it's ourselves. We have to be very careful with how we conduct ourselves when we're using web-based applications, and we perform a lot of phishing tests to determine the extent to which that risk exists. And I will cover that later on today. The other thing that we do have is the One Health and Care shared care record. It's being well used for direct care purposes, and we're doing active work in supporting progression to analytics, secondary use, and population health management. Population health management, we have had a number of conversations with neighbouring and other ICBs, including Frimley, Greater Manchester, Cheshire and Merseyside. And I have put a link into the document and the report pointing to a very emotional address at the last ICB board that they held as to how they're supporting their population through population health management. The NHS app is well used at this point. I think the major catalyst was COVID, which drove adoption. But the fact is we are implementing Patients Know Best across our system as a patient engagement platform, and patient empowerment is absolutely critical moving forward. I would just finish by saying that there are a couple of challenges. The one is around our ability to use data effectively to make optimal decisions for care. And we're putting in a CAG application, section 251, so that we can make use of our shared care record in driving analytics. And the other point I would make and ask endorsement from the board is that I think given the grip and control that Paul talked about, we need to do likewise on the digital side, and we need to increase control of all digital spend. Now we've got the right governance structure to do that through the Digital Collaboration Forum. And I would ask endorsement that body has the authority to review all digital spend. And finally, in closing, I have added at the end of the report some model hospital information, which is available publicly on NHS Futures. And I think we need to recognise that we have uneven distribution of allocation of funding across our healthcare providers. A couple of them are kind of at the median. Our acute is below. Now that can be perceived in two ways. That can be a good thing because it shows fiscal control. On the other hand, we need to just be very cautious with underinvestment in digital. And so all I would ask for is some consideration as we move into financial planning as to that level of investment. And I'll leave it at that point. Thanks, Chair.
Thanks very much, Chris. Great overview there, a very important area. I'll just pause if there are any immediate questions that colleagues want to make. We've got a couple, Julie and then Jack.
Really sorry, David. I think this is really timely, and thanks very much, Chris. I really like what's set out in there in terms of the roadmap, but I'm just struggling a little bit how they relate to each other. Does what needs to come first, or how do they relate to each other? And the other thing is how that roadmap supports our portfolio plan, the recovery plan. And then when you talk about actually asking for approval around that control of digital spend, it relates to my first comment. Is there a clearly within that governance structure, which is quite complex looking at it from afar, is there an agreed vision about what are the priorities? Because we haven't got unlimited amounts of money, we haven't got unlimited amounts of time. What is it's going to make the most difference, and how we'd like to therefore control digital spend? Is there a shared view? What will help us deliver those portfolios and that recovery plan, I think, is.
So, Julie, thank you very much for the question. I will just say that the digital function is not centralized per se. It is a federated function across all the CIOs, across the various different stakeholders. And that's part of my paper, was defining the principles for that operating model up front. And each one of the CIOs have taken responsibility for engagement through the portfolios to make sure that our digital roadmap absolutely aligns with each one of the portfolio plans, as well as the recovery plan itself. So I think that's the first point. Regarding digital governance, what we observe, Julie, as we've moved forward from the days of STP and CCGs into the ICB and ICS, is that it starts to surface a high degree of duplication of effort across individual trusts and organizations. And so I think that's one of the key areas. You're quite right, there's not a lot of money for digital investment. However, what we can do is we can avoid duplication of effort and avoid taking on and procuring new systems where that capability might already exist within one or more of our organizations.
Thanks,
So
Chris.
in terms, sorry, David, in terms
Yeah.
of a shared vision about what the priorities are for that limited, is there a clear shared vision for priorities?
There certainly is a shared vision across the key digital stakeholders across all organizations. We meet on a fortnightly basis and we discuss all of this, as well as at those governance bodies.
Thank you.
Thanks for the questions, Julie. Really important. Thanks, Chris. Jack?
Thanks, Chris. Really important. Very much agree with all the points you've made. I think there's that need. One thing I would sort of say conceptually is that for me, the cost is an issue, but I would counsel against the spend into the infrastructure, and yet the transformation piece around the willingness and to use the technology and to adopt that technology is, for me, very much the most important thing. So as a practice that's been very much sort of being pro-digital, it really took the pandemic, certainly in general practice, to change what I've been trying to do for 2 to 3 years. I don't think we can wait for another pandemic for us to decide that collectively as a system we want to work together, nor do we want to spend an eye-watering exhaustive amount for us to start working together. So I think I would like to have a shout out for the cultural piece. And I think that is a far more important thing, because I think if anything in the last 3 to 5 years, one thing I've learned is that we don't know what the future holds. So in some ways, I would say I don't think it will cost as much as we think it might. I think for us, I'd like us to spend more time how we will start working together. Where there's a will, there's a way.
I very much welcome your comment, Jack. The fact is, we work very closely with Dr. Paddy Haddingham, who's just popped up on the screen, as well as Dr. Sia Din. So the digital and the CCO functions, I think, are tightly knit together. And I think we've got the core infrastructure in place. The adoption and the business change is an area, it's a particular challenge we need to focus on. So thank you very much for your comment.
Okay, thanks very much, Chris. We're being asked to receive and be assured as to the ICS digital transformation progress against the digital roadmap, and thank you for that. And also just to note the recommendation that you'd like to move to that authority to control spend, which is something that I'm assuming will be discussed after the board today in terms of how that is transacted across the system. Yeah. So thank you very much, Chris, for attending and presenting that important report. We'll move into item 11 if we can, the winter surge plan, and Phil, I'll hand over to you.
Thank you, Chair, and I'll just give a few minutes of overview for this, recognise the volume of pages that's presented to the board today, but I'll try and just summarise that up. So the system surge plan for winter has been developed over the last 6 months by all system partners and coordinated through the urgent and emergency care portfolio governance. So board today is being asked to ratify the decision of the System F&P Committee in October to approve the surge plan. As I say, the paper presented today represents the culmination of a significant development and governance journey, which page, I think it's 53 of the pack, sets out all of the places where the plan has been considered and approved, which includes the public boards of the NHS partners on this call and local authority forums. It's also been subject to a deep dive session by members of this board in October. So given the fact that Surge touches all parts of the system, it's entirely right that the plan has been developed with strong clinical professional input, along with operational and then workforce quality safety, finance, comms, BI colleagues. The plan's built on the learning from last year and replicates the format of the plan of last year unapologetically to provide a consistent approach, which we all recognise. Plan's essentially split into three parts. So firstly is the capacity plan, which is built on the demand model, which we developed last year, updated to reflect the learning from last year, the demographic changes from last year, and some key underpinning assumptions, such as the protection of elective capacity over winter. We have increased the sophistication of the modelling, which has localised our understanding of the key capacity challenges, which are largely focused around the medical bed base at the Royal Stoke Hospital site. Capacity schemes are set out on page 56 of the pack, which fall into one of three buckets: either direct acute capacity, so physical escalation beds, acute equivalent capacity, so this is where we bring in the likes of virtual wards, community beds, and then the third bucket is enabling capacity, which doesn't have a direct mathematical tangible impact on the bed position, but provides the right environment to ensure that people are receiving care they need and not escalating into hospital. So an example there is the 5,000 additional primary care appointments per week, which we'll be putting in play from the beginning of December. So schemes have been funded either via ICB allocations, system partner allocations, NHSE monies and local authority winter monies. But I am very, very clear that in our financial context, it is essential that we can demonstrate impact and value for money against each of the schemes that we've put in place. We've also, which I think was a key bit from last year, strengthened the input from the voluntary sector this year. So you'll notice particularly about engaging with voluntary sector to support with discharge and settling in services to home, and also the significant role that the hospice sector is going to play in supporting us this winter. Second part of the plan is the escalation plan, which essentially outlines the measures that we will take as partners to minimise patient safety risks in the system in times of escalation and spread that risk out between different points of the system to avoid bottlenecks. Very much a challenging area of this that we continue to work on, but it is a key part of our plan. And then the final part is the system workforce plan, which sets out additional workforce recruitment and retention initiatives, things like bank rates and system level activities to manage and mitigate workforce risks. So risk is the key word, really. The plan carries a considerable level of risk, which we are monitoring through our risk registers. It's important in that context that the plan remains a live document that we continually review and recalibrate in the context of the pressures that we see and also any opportunities that we come across. In terms of the oversight of that, we've got our system coordination centre in play 7 days a week, which looks at the operational live position. And then we've got a weekly system surge meeting, which looks at delivery of all of the winter schemes, reporting into UEC board and finance performance committee. Last point, just while we've focused on surge for this winter in what's presented in front of you today, we've now got an annualised view of demand, which will help us better navigate periods of surge which occur at other parts of the year. And also, linking back to conversations earlier around system recovery, we've got a 5-year view of demand growth, which will very much play into those system recovery plans that focus on frailty, the JFP and other system plans. So I will pause there. Hopefully that's a helpful short overview, and hand back over to you. Thanks, Chair.
Bill, thank you very much for summarising, as you say, a lot of detail there. into a great overview. So Phil, just quickly, I just want to acknowledge the enormous amount of work that's gone into the production of this through you and system partners. So a thank you there. It's also great that the work of the VCSE sector has been acknowledged in this process. So again, welcome that. So just pick up any points on the plan. Chris, can take your question first, please, and then Showcat.
Yeah, and Phil, great plan and great engagement. But unfortunately, every time you read it, you spot something. The one thing that was missing for me in where you've got the three areas around capacity escalation plan and system workforce plan was the actual de-escalation element of it. And I know that's something that sometimes gets us from a financial perspective, but also from a workforce perspective. And I didn't find it in the narrative. So if that's just something we could consider about how we proactively do that, and clearly that's a risk-based decision as well. But I think just being explicit would be helpful.
Thank you, Chris. Really important point. And I think we've previously been guilty of planning assuming winter ends on the 31st of March and everything steps down at that point. And that is not the way that things play out. So as I say, that annualized view of demand now means that we can look at that de-escalation. Essentially, when you look at the curve of demand, it's very steep into winter between October and December, and then it's a very slow and gradual line out that takes us through to around May or June time in terms of fully emerging from that picture. So the system surge group will be tasked with a de-escalation plan. As I say, it was a key point of learning from last year that we didn't have that level of sophistication that we needed. So we'll absolutely be doing that. Thank you.
Thanks, Chris. Showcat.
Thank you. Thanks, Chair, and thank you, Phil. And Phil, I just really want to pick up on the workforce element of this, because last week we spoke about this at the People, Culture and Inclusion Committee as well in quite some detail. So I really appreciate the whole thinking around workforce and some of those challenges. And we spoke about the gaps. And I think, Phil, one of the questions I was putting to mission colleagues was really around the challenge of, have we got the workforce to address that particular demand? And if we haven't, what do we then do? And just trying to pick that up as a particular concern and issue, because all of this is dependent on the workforce, isn't it?
Yeah. Thank you. If I start off, and then I'll just let Mish pick up, because Mish has led on that element of the plan for us. But yeah, you're absolutely right. Workforce is the highest risk on our UEC risk register and indeed on the system winter plan. And for me, it's particular pockets of workforce that concern me most. So we're reliant increasingly on acute care at home, the virtual ward model, Chris, everything that we're doing in that space. And for example, ACPs are a resource that's very much in demand, and we struggle to have to fully meet the need that we're setting out. So for me, I've got concerns around particular pockets of workforce in terms of how we meet that, but I'll hand over to Mish in terms of the specific detail.
Thank you, thanks both, and thanks Showcat for referring to the conversation that we had at PCI on this. I think that as we go into winter, we need to continually evaluate both workforce supply and demand. In terms of the actual plan, we as organisations and supporting organisations are clear about the internal requirements for each of the schemes. What we need to really understand and continue to evaluate is what is the gap internally, so that we can be really clear as partners about what might be needed to happen to actually move people into the right place if and when required. So that work's ongoing. Of course, I can talk to you, and I've it's all in the pack in terms of the detail about all of the recruitment strategies that are happening, the retention work that's ongoing. As Phil mentioned, there are very specific pockets of workforce that we do struggle with, so quite specific and I guess tailored recruitment for the ACPs, and perhaps thinking quite differently in terms of workforce models of how we reach out into our community to try and use our workforce in a different way. It is a concern, Showcat. So in terms of full assurance on that, what I can tell you is that we're absolutely revisiting this on a sometimes daily, weekly basis to really understand actually where the gaps are. What is really positive, though, is since COVID, we have got our workforce mobilisation cell, and that is utilised on a daily basis. We've got our staff system workforce hub, So we use those resources in the right way. But thank you for bringing it up. It's a risk that we have discussed, and we will continue to in our people committee.
Thanks, Mish, and thanks, Showkat, for the question. Paul?
Just a very quick comment, David, just to say that it's great to see, Phil, and to hear that we're beginning to move towards an all-year surge plan rather than a winter surge plan. As you said, winter doesn't finish necessarily nicely on the 31st of March. That all-year plan allows us to do the de-escalation that Chris was talking about and so on, which is great. We can do that up and down. Great to have seen the amount of clinical involvement there's been this year and so on in terms of doing this and building that alongside the operational workforce colleagues. And I guess the final one is just to good to see that very clear link between this plan and the primary care plan, as well as the elective plan. So we're starting to bring all of this together, not talk about things in isolation, and we'll continue that work. So brilliant piece of work, and thank you.
Thanks, Paul. Jack, finally from you.
Thank you, Chair. So firstly, kind of recognise the financial pressures and also the workforce pressures in recruiting roles and perhaps people that don't currently exist in the system. What I would say, however, sort of like to end on a positive note, is that the system's probably more permissive than it's ever been in my time in general practice and the NHS. So I'd like to have a big shout out to the People's Hub, sort of Mish's team and Alex Brett prior to that, and I think around both the local higher education institutes, both at Staffs Uni and Keele Uni. I think there are lots of opportunities and lots of innovation going on. I think that, again, come back to the cultural piece around how we change in terms of how we do things. We've got modern general practice, new models of care, new ways of working, the long-term plan. I think the hardest bit then is how do we take others around us with this in terms of that cultural and having a tight grip at the same time on the governance and the safety aspects of it. Thank you.
Great summary there, Jack. Thank you very much. So, Phil, we are being asked to ratify the decision of the Finance and Performance Committee and confirm approval of the system surge plan for 23-24. That's the recommendation. Just check with the board that they are content to do that. Phil, once again, thank you to you and everybody involved in the production of this massive piece of work. Well done. Thank you.
Thank you.
Paul, if we can move into item 12, and I think you and Paddy are taking this, the system level access improvement plan, although I've just seen Sarah come in on screen. Hi, Sarah. So I'll hand over to you. Enclose your 10.
Yeah, thank you, David. All I'm going to do is just to introduce this very quickly. As you say, it's a snappily named system level access improvement plan, which rolls off the tongue. This is brought here for information and assurance today, in advance of us having to take this to publish it in March next year. Sarah, as you know, is our portfolio director for primary care. Sarah's just going to take us very, very briefly through the paper with a couple of key points, and Paddy's here to answer all the difficult questions.
Over to you, Sarah.
Thank you, Chair. So as Paul's reflected on, a national delivery plan for recovering access to primary care was published by NHS England in May 23, and that was to help address the challenges within general practice, and ICBs are required to have this plan in place by March 24. So we've brought this as a draft plan for comment, for feedback. It's no way a final plan, and we want to make sure we get this right. So we already started working on this ahead of its release in regards to our general practice strategy, but this plan actually goes further in its ambitions than what our general practice strategy does. So it's pretty essential and critical at the moment. General practice is under extreme pressure. It has an intense workload. There are workforce challenges, and it's struggling to kind of maintain that level of service that meets the demand that the public have. And in addition to that, that accessibility needs for our patient populations. So, you know, we already know that people want to be able to get through to the GP practice on the telephone at 8 a.m. and want to know, you know, how their appointment request is going to be dealt with. So the plan's ambitions are to improve patient experience by making it easier to access the right care at the right time by the right professional. Improve capacity and capability, so ensuring that we're empowering our patients to take control of their health, but also recognising that self-referral treatment pathways are in place. So it is really important to note that the plan is not just solely reliant on general practice in isolation. It is, it goes further than that, and we need to ensure that we're working with our partnering providers. And equally, we need to make sure that we're growing and supporting our workforce and attracting that workforce, which links in nicely to the previous conversation that was just happening. And the third thing really is cutting the bureaucracy, so empowering people to work together across those organisational boundaries. So the interface work that's been happening between general practice and other providers, making sure that's got a clear, transparent routes and focusing on those solutions together. So that's all I wanted to say. You can see the plan is very, very detailed, and clearly we've only got a few minutes. So in the essence of time, Chair, I'll open it up to questions if there are any.
Sarah, thank you very much, and thanks for summarising that. And as I've just said to Phil about the winter surge plan, there's clearly been an extraordinary amount of work put into the development of this, and that's evident from the papers. So thank you and well done to everybody involved. We will just take any points that any board member may wishes to raise on the plan. Okay, it looks as though you've covered most of those off in the report, which was pretty clear. So Sarah, with this, Paul said this will be published, I think, in March next year.
So that's our final submission date. So we would appreciate any comments, suggestions, and the plan will evolve up until that point where it will be hopefully signed off by this board ahead of being submitted to NHS England.
Right, okay, thank you. So I can't see any points anybody wishes to raise. So if we take the recommendation to note the contents of the plan, discuss any amendments required before the final version is submitted in March 2024. And Sarah, I'm assuming this will go through various committees to allow that final polish, of the plan before it actually comes back for final sign off. But it's great to see it upstream at this stage in readiness for that sign off. So once again, thank you, colleagues, for bringing that to today's meeting. So we'll move on, if we can, to item 13, the Quality and Safety Committee Assurance Report. Becky, are you taking this?
I
take
am,
the paper
Chair.
as read, if you could bring any exceptions out, and then I think Megan is presenting the non-executive exception report on behalf of Josie afterwards, which is enclosure 12. So over to both of you. Thank you.
Okay, thank you very much, Chair. I'll be brief because, as you said, quite a detailed paper that we've provided. The key exceptions are that we have got reference to the PSERF, the patient safety framework, which will be launched throughout autumn. The framework has been part of our deep dive within our QSC, and we've also taken a look at the plans and policies that have been provided by our NHS providers with the view of alignment and making sure that we're all working collectively towards achieving what we need to through the new framework. Just also to note, whilst UHDB are waiting for their CQC formal report, both our maternity improvement team and UHMs have offered support to those within UHDB, having gone through quite a significant amount of work that has been progressed through our LMNS board over the last few months, just to provide some supported learning. Also to note is that throughout the report, we've also identified our assurance frameworks for, sort of gathering the information, and also how we feed that into our continuous quality improvement programs across all of our providers. In particular, also referencing the fact that we are taking, due care and attention for our out of areas. So whilst we've got quite a lot of focused work within Staffordshire, that is not going to, to overshadow the importance of making sure that we've got exact equity across those services that our residents access outside of the Staffordshire borders. I'm going to stop there because, like I say, it's quite detailed, and Megan's got, sort of quite an extensive report in terms of the plans and policies that have also gone through our committee over the last months.
Thanks, Becky. So, Megan, if I could ask you to take enclosure 12 for us, and then we'll open it up to any points anybody wishes to raise.
Thanks, David. I just want to pick out 4 ratifications, please, and one comment. First ratification is in relation to the ICB quality strategy. The committee did approve the quality strategy. Unfortunately, it hasn't made it onto the agenda today, but that will come forward in December for board's ratification. The second one is around the partner patient safety and incident response frameworks. We agreed those frameworks for 4 organisations, which had already been through their own governance processes, and asking for board ratifications of those, please. The third one is in relation to community healthcare equity policy, which again the committee approved and recommended board ratification. That has been through patient and stakeholder engagement, and an equality impact assessment has been undertaken and was positive. And the final ratification was in relation to the Quality and Safety Committee terms of reference. There's a very minor amendment to that, which needs ratification by the board. And then the final comment is in relation to review health assessment and initial health assessments. The committee did ask for a report due to the significant backlog in relation to these assessments. We received a detailed report. A number of risks were set out in that report. We weren't sufficiently assured and asked for further reports to come forward in February regarding that. Thank you.
Becky, Megan, thank you for that very full report. And we note those recommendations, Megan. I won't go through them again because they were quite extensive. Just check if there are any points of clarification any board member wants to make regarding anything you've said. If not, we will move to those recommendations and approve them. Okay, thank you, colleagues. Thanks, Megan. Thanks, Becky. So that takes us into 14, Paul, Finance and Performance Report with Phil. So if I could ask you to pick up any escalations to the board from the paper as submitted in enclosure 13 and 14.
Okay, thank you. I recognise we're a bit behind, so I'll just be very, very brief because the report has been scrutinised already in Finance and Performance Committee. And just draw your attention to page 221, the placemat, as we call it, which I think is quite a helpful way of just looking at where we are, because it shows often we concentrate on the things where we're behind, and rightly those are the issues for escalation. But you can see in that there's quite a bit of green as well, and some amber where we're behind, but we've got some mitigations in place. And of course, there are some red areas which are flagged in the report. The financial position I've kind of covered within the recovery plan. I mean, at month 6, we were 53 million adverse to our plan, and so we indicated that we are headed for a 141 million deficit, unfortunately, but that's before the impact of the recovery plan. We've got conversations last week. You'll have heard announcements in the press. Additional funding came into the NHS to cover the costs of industrial action. Some of that is flowing down to us. So we are required to resubmit plan next week. So we're working through that at the moment, and that will be responding next week. And we'll obviously update the board on where we end up to in terms of the forecast outturn after that. We certainly expect a fairly material improvement on the 141. As I indicated earlier, the recovery plan is going well. It will make quite a big difference to that deficit, but we don't think, unfortunately, enough to get us back to break even. But as I say, we'll report further next time. I don't know whether Phil wanted to say anything about the other areas of performance.
Thanks, Paul. Phil?
Yeah, thank you, Chair. Thanks, Paul. Just very briefly, because obviously I've already talked through urgent emergency care in some detail in terms of the winter plan, which is very much upon us. So those seasonal pressures are starting to play out. We've had 7% increase in demand, which is referenced in the report. Particular challenges during October, where we had 2 periods of business continuity incident at UHM linked to the UEC demand. From a infection point of view, COVID, which was previously quite high again, does seem to have dissipated, but we are seeing the beginning of the seasonal flu type curve with RSV levels currently quite high, so we're keeping close to that and projections around it, and our focus very much is on the deployment of those surge schemes outlined earlier. From a planned care point of view, we're continuing to work through what we can in terms of recovery for the long waiters. We do still have 1 patient, albeit a different patient to previously reported, who we are reporting as a breach looking ahead to the end of the month against the 104-week wait position. This one is a very specific case where we're waiting for delivery of a custom shoulder from Italy, so there's some complications related to that, but we are tracking it closely. The 78-week wait position has improved, so we're looking at 152 across UHM and Nuffield in October, reducing to under 100 in November. And we're currently working through December, but we're looking to obviously try and eradicate all of those 78-week waits as soon as possible. Good progress overall with the journey to 65-week wait by the end of the year, although we are still facing some particularly challenged specialties, particularly around neurology, respiratory and spinal, which we're working on. And as part of the work that Paul's outlined previously, we're looking at what those trajectories will do for the rest of the year. The other bit just to note is that University Hospitals of Derby Burton have recently entered Tier 1 national oversight for their elective delivery as well. So that's the same position as we're in over on the UHM footprint. So we're monitoring that position closely, and the latest data is showing we have just over 70 of our residents waiting over 78 weeks at UHDB. So again, linking closely with that. Lastly, around cancer, we've welcomed some additional funding from the Cancer Alliance, which has enabled us to do some additional targeted capacity at colorectal, skin and endoscopy backlogs, and that is already having a really positive impact. So we are returning to our trajectory to meet our allocations, our fair share allocations as it's termed, in terms of cancer backlogs for the end of the year. I'll pause there, happy to pick up any details.
Thanks very much, Phil. Again, full report. Just pick up on anything anybody wants to raise. And Megan, while we're waiting for that, if I could ask you to give any exceptions as chair of the Finance and Performance Committee that you want to make.
Given the time, David, I'm happy for people to take the report as read. It's quite a detailed report, and answer any questions if there are any. Thank you.
Thanks for that, Megan. So any questions on this agenda item, colleagues? Looks like the extensive reports have satisfied the curiosity of board members. So if we can note the exceptions highlighted in the reports and receive those, that would be great. Thank you. Thanks, everybody. Item 15 is the board assurance framework, and Tracy, I take it you're taking this, not Claire.
Claire sends her apologies today. So Thank you, Chair. So you received the Board Assurance Framework in its second quarter. We have been refining the process, as you all will know, working on a system basis. So the BAF has been to all the committees. Having said that, the timing has been challenging, and I know that there will be some questions from board perhaps on a certain BAF subject. But basically going forward, we are looking at the timings of our business cycles and how we can provide the scrutiny of the assurance against each strategic objective in a timely way. And there's meetings will be set up with the exec lead and the chair of each committee so we can assure that happens. There is a summary version that is in your pack that you may find useful. Again, it's about development, and the governance and risk network are looking at developments of how we can show highlights of a long document that is more easy to understand and possibly easier for the public then to follow in terms of our assurance. We will be looking at refreshing our BAF come March next year, even though if you look at some of our strategic objectives, they are quite long-term objectives, and they may not significantly change. So in terms of the BAF that we present it now, there is a statement in there about BAF 7 remaining a high score, though reducing. There is questions from Finance and Performance Committee and Audit that may want to be raised here for us to review that position. Apart from that, Chair, I'll stop now, given the time we're on.
Okay, Tracy, thank you for that. And just quickly, Megan, Julie, if there's anything you want to just come in on Tracy's point there about finance and performance and audit. Julie.
I think Megan and I are probably going to say the same thing in terms of the comments that were made at finance performance. It was circulated to audit. I don't think either of us feel that there is sufficient evidence to reduce BAF 7. Can I just say one other thing? I think that the mock-up of the risk map would be very useful. I've said this to Tracy, circulated with the notes from today's meeting. And I think just on another point, there are many things or a few things from today that would be usefully circulated from our comments, the infographic type, and I would commend the robustness of the process that's taking place here.
Thank you very much, Julie. Megan?
Nothing further to add. I agree with Julie's comments. Thank you.
Okay, thanks, Megan, and thanks, Julie. Tracy, thank you. Just pause in case there's any further points anybody wishes to raise. If not, we're being asked to be assured that the ICB is on course for delivery of the strategic objectives by their target dates within the BAF. And Tracy will just note those points that Julie raised, just in terms of the further review out of today and then further issues that require just a final review as part of the review process. Okay, thank you, Tracy. Item 16 is the People, Culture and Inclusion Committee Exception Report. Showkat, can I invite you to give any exceptions you want to bring to the board's attention today, please?
Thank you, Chair. I'm just conscious of time, so I'm just going to make two very quick points. We've already spoken about the surge plan, and it was great to see that come to the committee itself. But we've seen some real improvement around turnover and also sickness absence. So in terms of retention rates, what we've done is a comparator from last year, and there has been a just over 2% in terms of turnover, an improvement in terms of the number of people leaving. And then in terms of sickness absence across the system, we've also seen just under a % improvement there. And I think that's really good to see, bearing in mind all the initiatives and the different projects and programs that colleagues have been working on. So I just wanted to share that. The more detail is already there in the report.
Thanks very much, Showkat. Just pause if there's any further comments on the report. Julie?
You're going to hate me today, David. It was just to commend, the People and Inclusion Committee, the summary. The attachment to that, I think, I keep saying this, I think needs to be brought into other parts of the agenda. It's a really useful attachment. We talked to it. It could be brought into the chief exec, potentially into the performance report. It's about pulling all three things together. We talk about triangulation. So for me, I would really commend that, please.
Okay. So Tracy, if we could probably have a look at that for future agendas. Julie, thank you for that. So we're being asked to ratify the decision made by the People and Culture and Inclusion Committee to proceed to signing up to the NHS Sexual Safety Charter and to receive the report by exception. Okay, so just ask if there is any other business anybody wants to raise today. I've had nothing brought to my attention in advance of the meeting, but anything anybody wishes to raise? Thank you. Just ask if we have any questions from the floor relating to any discussions that have taken place during the course of the meeting. Ian, welcome.
So be very quick, Chairman, because you had a huge amount of work today on your agenda. Within the Systems Recovery Plan, product identification, one of 3. It's about a key team. Chris, workforce remains fragile due to significant loss of experienced staff to primary care ARRS roles. I know previously ambulance services were losing paramedics to these same roles. This has been going on for quite some years. Now, I understand where you're coming from, recruitment requirements, etc., but we are talking about a key team involved in your recovery plan, the winter surge plan, and any surges throughout the year. How are you going to mitigate this situation? Because that seems like an extreme challenge to me.
Ian, thanks for the question. Mish, are you able to pick Ian's question up?
Thank you. Yes, really happy to. In terms of that particular point, what I think we are seeing is career progression. So colleagues are moving, and what we're trying to consider is what a portfolio career could be like for individuals. But I acknowledge that it is a risk. It's obviously in there as a risk. What we need to do is to work more closely together as organisations to ensure that individuals can have their career progression at the same time as still delivering the services in the right place. Ours roles are an absolutely integral part of primary care, but also reaching into secondary care in terms of the value that they offer. So we wouldn't want to stop colleagues from being able to go into those roles. But I think, Ian, you make a very good point that this just does highlight the fact that we have got such a workforce risk. We need to try and ensure that our workforce experience is really good. They feel valued, they can have career progression, but also that we are able to get them into the right place so that our patients and our citizens can be served. So we'll take the point. If you want me to find out the absolute detail behind that point, I'm really happy to do so and to feedback. But that would be my position at this point.
Thank you. I'm taking you up on that offer. Thank you very much.
Yes, absolutely.
Nothing more.
Thank you, Ian. Thanks for your attendance and for your questions. Okay, just in terms of meeting effectiveness, just want to check that everybody has had ample opportunity to raise any issue that they wanted to on any item on the agenda, and that we've followed the compact that was discussed at the beginning of the meeting. Jill, just in terms of the next meeting, given the depth of the agenda we've had today, we might just want to factor in another half an hour to give us ample opportunity. There's a lot of information that we've had to get through in a relatively shortened period of time today. So if we could pick that up again for the meeting that we have in December. So if there's no other business we need to transact this afternoon, we'll close. The date and time of the next meeting is the 21st of December at 1 o'clock. That will be held in public, and it will be in public at the Newcastle Room Beaconside Conference Centre in the Staffordshire Education and Enterprise Park. So once again, thank you to everybody for presentations and contributions today. We'll close the meeting at that point. Thank you.